They reduce cardiac workload and slow down the heart rate. Beta blockers and calcium channel blockers reduce myocardial oxygen requirements by decreasing workload. They slow the heart rate and reduce myocardial contractility. Finally, nitroglycerin is used for vasodilation and antiarrhythmics to stable erratic or otherwise abnormal rhythms. Now, as promised, cardiac catheterization. Sometimes cardiac catheterization is done right away, before any of these other tests. It takes a lot of teaching to be sure the client knows what to expect. Cardiac catheterization is used to assess the location and extent of coronary artery obstruction. It allows visualization of the heart chambers and the coronary arteries, measurement of pressures in the major blood vessels and the heart chambers, and assessment of valve function. To catheterize the right side of the heart, the catheter is threaded into the femoral vein and advanced into the vena cava, right atrium, right ventricle, and pulmonary artery. Pressures are then measured. When the left side of the heart is to be studied, the catheter is inserted into the femoral artery and advanced into the left ventricle or the coronary arteries. Dye is injected to visualize the cardiac structures via fluoroscopy. Cardiac catheterization carries a risk of complications, including bleeding, hematoma formation, infection, and thrombus formation. Care of the client having a cardiac catheterization includes explaining the procedure to the client, obtaining an informed signed consent, and telling the client to expect to feel flushed when the dye is injected. It is important to inquire about seafood or iodine allergies. Remember, it's nothing by mouth according to agency protocol, so find out when your client last ate. Administer sedatives as prescribed, and explain to the client that the table is hard and may be uncomfortable. The client will be asked to take deep breaths and to cough to clear the dye out of the coronary arteries. What post-procedure care is needed? After the procedure, monitor vital signs and circulation in the extremity into which the catheter was inserted, and check the puncture site for bleeding or hematoma. Then, enforce bed rest for a specified period of time so that your client doesn't dislodge the clot. If a vascular sealing device is not used, maintain pressure on puncture site per protocol using a C-clamp or Biotech plug. Remember to assess peripheral pulses, distal pulses below the procedure site, and the groin pulse, as well as the site of the catheter insertion. Besides cardiac catheterization, several surgical options to improve myocardial perfusion are available. There is percutaneous transluminal coronary angioplasty, PTCA, also done in the cardiac catheterization laboratory. A catheter is passed through a peripheral artery and into a blocked coronary artery. A balloon in the catheter tip is then inflated to compress the plaque, enlarging the arterial lumen. The effects may last for years, but more often, restenosis develops earlier. There's laser angioplasty, which is similar to PTCA, except that the lumen is enlarged when the plaque is destroyed by a laser in the catheter tip. There's coronary atherectomy, where the physician uses a device that shaves plaque off the interior walls of the coronary arteries. It, too, is performed in the cardiac catheterization laboratory. After the plaque has been removed, a stent can be placed in the lumen to support it. And finally, transmyocardial laser revascularization, a procedure that is quite different from the others because it requires a thoracotomy. A laser is used to create 20 to 24 tiny holes in the myocardium. The holes provide channels for oxygenated blood to flow into the left ventricle during diastole. Nursing assessment of clients undergoing these procedures includes monitoring vital signs, cardiac rate and rhythm, ECG, pain, anxiety, and fear, as well as bleeding, bruising, and oozing at injection sites. Nursing interventions include pain management as a priority because pain contributes to the stress response and to anxiety, both of which increase cardiac stimulation. Morphine sulfate is the preferred analgesic after AMI. Nursing interventions for ineffective cardiopulmonary tissue perfusion include administering nitroglycerin sublingually or intravenously to dilate the coronary arteries. By improving myocardial perfusion, pain is relieved. The administration of thrombolytics and anticoagulants is intended to dissolve existing thrombi and prevent the formation of new ones. The primary adverse effect of thrombolytics and anticoagulation is bleeding. Therefore, you must monitor baseline and subsequent INR, APTT, platelet count, and fibrinogen, and avoid invasive procedures. Fibrinogen may be given for uncontrolled or other serious bleeding. Be sure to anticipate dysrhythmias when thrombolytics reestablish blood flow. What are the key nursing interventions for clients who have had angioplasty? Monitor for complications such as rupture of a coronary artery, dysrhythmias, coronary spasm, hematoma at the catheter insertion site, and restenosis. Assess for allergic reactions to the dye, hypotension, hypokalemia, and dysrhythmias. Administer drugs as prescribed, nitrates, calcium channel blockers, beta blockers, ACE inhibitors, and glycoprotein 2A/3B inhibitors. After stent placement, clients are usually on warfarin therapy for up to 3 months to prevent thrombus formation, while a smooth endothelial lining forms in the lumen of the stent. Teach clients on warfarin to report signs of excessive anticoagulation and to keep their appointments for blood studies. Clients who have an acute MI are usually admitted to a specialized unit. This admission likely confirms the client's fear that they are having a heart attack. Once these clients are stabilized, explain what is happening and what you are doing and why. Acknowledge that the experience is frightening and assure clients and families that the unit staff is highly skilled in cardiac care. Try to create a restful environment. If the client is especially anxious, consult with a physician about prescribing a sedative. A primary nursing intervention for decreased cardiac output is watching for cardiac dysrhythmias. They are especially common after acute MI because damaged areas in the myocardium can act as ectopic pacemakers. The primary concern with dysrhythmias is that they reduce cardiac output by disrupting the dynamics of cardiac blood flow. Clients with acute MI are on continuous cardiac monitoring until stable to detect dysrhythmias. The prompt recognition and treatment of dysrhythmias can be life-saving. Dysrhythmias disrupt the dynamics of circulation, so they must be treated with a pacemaker, antidysrhythmics, and correction of the cause. Electrical defibrillation may also be used. Cardiogenic shock, the most common cause of death after AMI, is usually related to extensive left ventricular damage. The symptoms of cardiogenic shock are like those of other types of shock. So what changes might you find? The client's blood pressure falls, urine output decreases, level of consciousness decreases, and the skin is usually cool and clammy. The medical management of cardiogenic shock includes intravenous fluids and drugs, intra-aortic balloon pump, external counterpulsation, and hemodynamic monitoring. The intra-aortic balloon pump has a balloon-tipped catheter that is inserted into the descending thoracic aorta. As the pump inflates the balloon during diastole and deflates it before systole, it reduces preload, thus improving cardiac efficiency. External counterpulsation uses pressure devices applied to the legs, such as mass trousers or sequential compression. A pump inflates the devices during diastole and deflates them during systole. This device also improves cardiac efficiency by reducing preload. Among the tools used for hemodynamic monitoring are the central venous catheter and the pulmonary artery or Swan-Ganz catheter. The central venous catheter allows measurements of right atrial pressure to assess fluid volume. The pulmonary artery catheter permits measurement of pulmonary capillary wedge pressure, which helps with assessing the function of the left side of the heart, right atrial pressure, cardiac output, and saturated venous oxygenation. The arterial line allows direct measurement of systolic and diastolic blood pressures. Drugs used to treat cardiogenic shock are inotropics, like dopamine, to improve myocardial contraction. How do you assess if they are effective? The client's urine output will increase, and heart rate and blood pressure will stabilize. There are also vasodilators to improve myocardial blood flow and reduce preload, and diuretics to decrease the blood volume and heart rate. As you can see, nursing care of clients who have an acute MI can be very complex. The outcome can be affected profoundly by quality of care. Vigilant monitoring and early detection and treatment